I'll get my colleague.
Minister, you're aware that hospitals have a duty of care?
Yeah.
Yeah, and
We all do.
Yeah, absolutely. And you're also aware that certainly in medical matters that includes a duty to warn?
Yes.
I'm curious about the draft press release that's dated December the 24th that would have warned the broader community and especially any visitors who may have been immunocompromised thinking about RPA, that there was a risk from fungal infections.
No.
Why was that press release never released?
Okay, well, it's a fair and reasonable question. So let me just take you through that, and I'll also ask Ms Wilcox to further elaborate on the question as well to make sure the committee has maximum information. There was a decision made, often we prepare, and again, Ms Mitchell would know from being a minister, often statements are prepared by...
Minister, I'm aware that you weren't actually in the office on December 24th. Who made that decision?
Could I just get through, because it's an important one. I'm happy to give you more time. Often the agency prepares statements about a range of different issues. They don't necessarily get out the way that it was in the initial draft of that. The decision was made that the priority was informing patients, outpatients and staff.
Decision made by whom, Minister?
Just give me a moment. We had to balance that, not my decision. I didn't make a decision not to put it. So
who did make that decision, Minister?
So we had to balance the fact that we wanted to make sure staff were informed, patients were uninformed. That's a large number of people, but we didn't want to unnecessarily concern the community about a mould that exists in the environment, and I did not want, or Health did not want, that to be a concern for them going into one of the state's largest
Minister,
hospitals.
do you not know who made that decision to withhold that information from the public?
Thank you, Minister. It is convention that draft statements are prepared in the event they're needed. It would be fair to say that...
Thank you, Ms Wilcox. My question has been repeatedly, who made the decision not to release that draft statement?
So
do you know the answer to that, Ms Wilcox?
I do.
Who did make that decision?
We took the question around releasing a public statement around this to the expert advisory panel, which is chaired by Dr Chant, had a number of senior mycologists from Westmead Hospital, Clinical Excellence Commission, our own transplant clinicians and infectious diseases clinicians. These things, and Dr Chant's far better placed than myself possibly, but these things are always a balance. We had a situation that was completely under control.
Sorry, just to be clear, so it was that commission chaired by Dr Chant that made the decision not to release, is that right?
We took the question of should we release a public statement to the panel. The recommendation was on this occasion it was not necessary. The situation was under control. The air sampling had indicated the air was clear, and the patients and the outpatients and the clinical staff who were directly affected were absolutely aware of the situation. No, we didn't need to contact visitors because the air sampling had showed the hospital was clean.
When was that decision made? Was that on December 24th?
So perhaps it's probably important to say that the focus of the issue on the 24th, and there was rapidly changing information, the focus on the 24th was to make sure that all mitigants had been put in place. At that stage, the ward was still having patients, and there was a discussion about risk management of where
I'm
those
really grateful for all the discussion about process, but the question is, who made the decision? When was the decision made? And I understand, Dr Chant, you chaired a committee that made the decision.
So at that
when was that decision made, Dr Chant?
So at the time on the 24th of December, when the committee was meeting, the discussion about the communication and who needed to be told and what was the nature of the thing was discussed, and it was considered that because there was lots of evolving information, that the people that needed to be advised were the people on the transplant ward, progressively the patients that were, when the clinicians defined a look-back period, the rest of the clinical staff in terms of why we were air monitoring.
Thank you. Thank you. I think that's the best answer I'm going to get, so thank you very much. So, Minister, there's a duty of care and a duty to warn, and the standard of care that duty requires is very clearly set out in the Clinical Excellence Commission Infection Prevention and Control Practice Handbook, which refers, of course, to the South East Sydney Local Health District procedures. You're aware of those that set as the standard by New South Wales Health for how these issues to do with infection control, especially with respect to Aspergillus, are dealt with?
I'm aware that we have strict infection control procedures and requirements as a part of the accreditation of hospitals, like other institutions, I'm assuming.
And those standards all talk about proactive measures that are taken, risk assessments that are taken, especially when there's any construction abutting transplant patients.
I don't have that document in front of me, but I'll take... You're a person who's reading it, so that's what I'll take it as.
And we heard this morning that the measures that were taken were after the deaths rather than proactively, and that deaths occurred. So we've got a duty of care and a duty to warn. We've got a clear standard of care that's a reasonable response to that duty. There are significant questions about whether that standard was met. Minister, what advice have you taken about the legal liability for negligence?
I haven't sought that advice at all. What my focus has been, and to be honest, what the two individuals, some of the finest public servants this state has ever had in Deb Wilcox and Dr. Kerry Chant and the team at RPA, as well as some of the best transplant clinicians, what they've been focused on is A, they picked up through clinical analysis a bit of an unusual trend. B, they then took that action, raised their concerns. We then took that as a system. Health took the subsequent action, what they did, and now we are having a look.
Minister,
and we're having a look at that and looking at that as a part of our investigation into those matters. So I haven't looked at the legal
Minister,
issues.
I'm asking you, I'm not contesting the excellent care given to patients in difficult circumstances. I'm not contesting the work done by Dr. Chant and her team or by Ms. Wilcox. What I'm asking you is, with the person who has overall responsibility for the system, who's meant to look at all the levers, who has the care of every patient in their responsibility, whether you made sure that the procedures of New South Wales Health were followed, whether you exercise responsibility, and whether negligence has occurred on your watch, negligence which has led to the death, sadly, of 2 people.
Point of order.
Well, that is a very, very,
The
very
Minister
big claim.
was responding essentially to that accusation because he was asked, have you taken legal advice in a particular context? He was in the course of responding to that, which is a very significant suggestion, and I would suggest he should be able to complete his answers without being interrupted with a barrage of further accusations.
Thank you. I'll go to the Minister to respond to that.
Ms. Carter, I'm not going to and would not ever preempt clinical review into when we have issues like this. I'm not going to do that, other than to continue to say that Health took all of the measures that it needed and felt was the best course of action at the time. If there are things as a part of the review that experts and Dr. Chant's team and transplant clinicians say to me, look, in the future we would do this, then I will transparently show that and highlight that, and I'm happy for people to look at that. But at the moment, I don't have that in front of me. What I have in front of me is a analysis of what the team did on the ground, doing what they thought was the very best pathway for these patients and the patients broadly in the hospital and the staff in the hospital. To be fair, I think it's reasonable for a minister to back them, given what they did and the time that they spent on it. This was not something that they just brushed aside at all. They informed patients, they informed staff, they informed outpatients. They took, based on their clinical expertise, a view about what needed to happen. Now, we've also taken the opportunity to have a look at this broadly, but I will wait to see what that review does, make it transparent in its nature. Importantly, before I do that, making sure that the community or the families involved have an opportunity to have their say as a part of that, and we'll be keeping them informed. I mean, that I think is the expectation of the community.
Minister, you'd be aware that New South Wales Health has a range of programs and services for children from 0 to 17 who've displayed or engaged in problematic or harmful sexual behaviours?
Yeah, I probably haven't had a direct interface with that, but I imagine it's in our sort of stronger communities and families type of support. But I'd probably need a little bit more information.
Okay. Safeways program is for children 0 to 10. Do you know what the waiting list is for that program?
No.
If you could take it on notice.
I can take it on notice.
Sure.
Yeah. Unless.
And
sorry.
happy to get it later.
Yep.
And the New Street Services program is for children 10 to 17.
Yep.
Minister, one of New South Wales Health's own experts, Dr. Dale Tolliday, gave evidence to the Legislative Council's inquiry into the effects of harmful pornography last year, that children and young people under the age of 18 are responsible for at least half of the abuse on young children.
Yep.
So is it important that these programs are properly resourced?
I think the exposure to pornography by young people, particularly young boys, is something that concerns me as a legislator, but it also concerns me as the dad of a teenager. This is a trend probably in recent times when the access to that type of violent sexual behaviour is a concern, I think. I'm going to say for all of us as legislators, but for the community. So, that remains a concern.
And we got clear evidence that this was one of the reasons for the rise in child-on-child, young person-on-child sexual assault.
It could be the case. I'm just not 100% sure of
that.
No.
But Dr. Tolliday indicated in his evidence that neither the Safeways program nor the New Street Services program, those programs that are specifically targeting children who exhibit problematic or harmful sexual behaviours, quote, can come close to meeting the demand for services at the moment. And he said further, quote, that waiting lists are not kept at those services. What are you doing to resource these services appropriately?
I just want to double check. This is a health program,
this is
not a facts or communities.
New South Wales health programs.
Right. Okay.
And this is evidence given by somebody from New South Wales Health.
I take it.
Yep.
Let me take it on notice. If I can get it, as I will always try and do during the committee hearing or this afternoon, you'll have it, Ms. Carter. I just
thank you.
Not aware of that specific program. But
okay.
But leave it.
There are two programs.
Safeways
for the under 10 and New Street for the 10 to 17.
Yeah. Apologies, I meant to.
In the committee's report,
Yep.
recommendations were made, one of which called on the government to adequately resource these programs. When the government's response to the committee's recommendations was received,
Yep.
it was essentially, New South Wales has this all under control and didn't flag the need for any extra resources. What exactly is your government doing to support young people with problematic and harmful sexual behaviours and, very importantly, drive down child-on-child sexual abuse?
Yeah. Elizabeth, do you want to make it?
Yes, thanks, Ms. Carter. That we will get some further information about the specifics of those programs.
And perhaps we can come back to that later this afternoon.
Yes,
that'd
but
be great, Ms.
I
Wood.
just would like to just say that
then.
we have actually New South Wales Health led the development of Children First 2022-2031.
Great. Perhaps I've got limited time with the Minister, Ms. Wood.
Sure.
We can talk later today, but thank you.
No problem.
Minister, eating. A service plan for people with eating disorders. Where are we with that? Will there be a new one that's prepared?
I'd have to take some advice on the
I can
currency
take
of
that, Ms. Carter. We're in the process of considering the evaluation and the next steps that need to occur for that work.
When will the evaluation be finalised?
I don't have a date, but we can certainly come back to that today.
And in the interim, who's responsible for managing services for people with eating disorders?
It continues as is, Ms. Carter.
On an LHD by LHD basis?
With statewide oversight, correct.
And who's responsible for the statewide oversight?
It sits within my division, but also within the mental health branch.
Thank you. I've got some more questions. We'll come back later today.
Ms. Carter,
Thank
it's
you very
largely led through the mental health service, so I'm happy to get back to you, but I just want to take some advice from Minister Jackson as well.
Sure. Is there a separate mental health budget, or does it come out of the health budget?
Well, there's a mental health budget that's a part of the health budget that Minister Jackson ably manages, and I know this space falls within that broadly. So it's not that we won't get back to you, we will, but I just want to take some advice from Minister Jackson and her team as well.
Yeah, no, of course.
Yeah.
Minister, do you think that there's ever any issues that arises with the mental health budget sitting inside the larger health budget, that there are so many competing priorities in mental health that something as important as eating disorders may have to fight for funding with other mental health needs?
Look, I think former Minister Taylor, and when she was the Mental Health Minister, and Minister Hazzard were, from all accounts, able to work through those priorities and challenges.
And are you confident you're doing that?
Yeah, well, I mean, I engage with Minister Jackson very, very frequently. She probably doesn't enjoy it as much, but
in terms of the need for provision for people with eating disorders, are you aware of the comparative death toll in Australia of people from road traffic accidents and people with eating disorders?
Not compared to that data set. I don't have that line of sight.
More people die of eating disorders than in road traffic accidents.
Yeah.
Yet, is the funding anywhere near comparable? Look, I'd be really happy if you'd take it on notice. I can tell you what the answer is. It's not.
Okay.
And
then you probably didn't need
it's
to ask
time
the
for
question.
action, I think,
Yeah,
Minister,
okay.
is what I'm suggesting. On another matter, Minister, you'll recall the testimony of Ms Ludford at the Budget Estimates hearing of the 2nd of December, and do you recall the letter that I wrote to you on the 4th of December in relation to that testimony?
I recently I've got some corro from you recently that I was reviewing.
It was sent on the 4th of December, Minister. I understand that you're busy.
Yeah, no, I recall it. Just give me the topic,
Okay.
and I
Ms Ludford's testimony, conscientious objection. I can give you a copy.
Yeah, no. I remember it, and
Great,
I've
thank you.
also had a chat to Mr. Donnelly about this. This is.
I'm pleased you spoke to Mr Donnelly. I'd love a reply to my letter from you, Minister.
I know that, but let me tell you that that right remains. That's an important part of healthcare. We understand that. We expect our department to follow both employment law and follow the Abortion Law Reform Act. That's what I understand. I think a response either has been or is being sent to you, but no, I read your corro, Ms Cutter. Don't worry about that.
Thank you.
I just want you to know that.
In the letter, I invited you to communicate with the LHDs to make sure that they were not drafting employment descriptions or employment positions in such a way that anybody with a conscientious objection would be unable to apply for those positions.
Yeah.
Have you done that, Minister?
I'm not saying that I have personally done it, other than I just want to say this though about it, because it's just important for me, other than to say that my expectation is that they follow industrial and employment law, and then they're also in the delivery of their duties are following other legislation, including the abortion law amendments. It's I think that should be all of our expectation, but
Absolutely.
Does anyone want to add? Fatima, sorry.
I can address that, Minister, thank you. We're in the process of reviewing the policy directive to ensure that we can provide advice to the districts about how to deal with these issues.
Sorry, which policy directives?
So we have a policy directive around conscientious objection,
Yes.
and we want to make sure that that aligns with the legislation, so we will be issuing some direction on that.
Is there any issue that the existing directive doesn't align with the legislation?
No, I think we just want to provide some clarity just to make sure that people are making the appropriate decisions, and as the Minister said, making sure that we're compliant.
So clarity
with
about what
compliance
issue
law.
exactly?
As the Minister indicated, we want to make sure that when people are writing position descriptions or advertising roles, that we're really clear about these issues.
So that they're really clear that it's illegal to discriminate on the basis of belief or conscience?
Yeah,
That's correct. We will reinforce those obligations in our
And that
communication.
Parliament was recently asked to reconsider the issue of conscientious objection in the Abortion Law Reform Act, and quite conclusively decided it did not wish to do that.
Yeah, we aren't changing the conscientious objection component. It's an important part of that. We respect that, and what I'm saying to you, I'm trying to be as clear as possible. I expect CEs, when they're doing these positions, is to make sure that it is following legislation, and that legislation is both industrial/employment as well as the existing legislation about it. But we're doing a policy directive review that I have touched base with Mr. Donnelly on, and I just checked with my office, Ms. Carter. I think
just a note, Minister. Opposition, government. So it's lovely you're talking to Mr. Donnelly.
No, I just wanted to say, because I just hadn't finished, but I just wanted to say that I understand a response has gone out to you.
Lovely, thank
in
you.
relation to that CORA.
Thank you.
I wasn't being.
Thank you.
Yeah.
Thank you very much. The Shepherd Centre and Next Sense, Minister, this was raised at the last budget estimates, and you'd be aware that it's wonderful when children get a cochlear implant. It can open the world to them, but they need to be taught how to use it, and that's where Shepherd Centre and Next Sense come in. And about 750 New South Wales children look to that program every year, and they look to you for funding. Has there been a decision made yet about continued funding?
No, but I'm aware of the issue and I'm working through it. I've met with both of them. I think I also had a chat with, I'll stand corrected on this, former Prime Minister, Mr. Howard, who I think is involved in the Nexus, but I'll rely on others to tell me that. I think so I've had a discussion both within my own community with Shepherd Centre and broadly centrally. We're working through what I would call all of the budget priorities and issues to date. We haven't landed on a decision around that, but let me assure you that I'm cognizant of the work they do. The work they do is important. As Minister Mitchell know, in big portfolios there are big priorities everywhere. All of them are important. We've just got to make sure that we can deliver the very best possible services for the allocation of funds that the community provide the portfolio.
Are you aware that the government of Japan, so impressed by the work that Next Sense and Shepherd Centre do, they reached out directly because they want the service that they provide for New South Wales to be offered in Japan, and they're funding them to offer them in Japan. Shouldn't New South Wales children have the same opportunities as Japanese children?
They have been having those opportunities, and I think from one of my discussions I actually recall that piece of information, though I'm doing, there's a lot of information in my head at the moment, so I'm just making sure that that is accurate. I do think there is I remember Shepherd Centre, I think it was, may have informed me around the work that they are doing with Japan, but we've also, as you know, Ms. Carter, got a world-class health system. It stands as test against any other health system in the world, and when we do comparators with our health system to other health systems, if you're going to be getting treated in a system, then New South Wales, well, it's by far and away the best in this country by the length of the strait, but it is one of the best in the world. Not perfect, a lot more work to do, a lot of improvements still to be made, but it is still a very strong, robust and effective health system.
Thank you,
broadly.
Minister.
Okay, thank you for that.
Can I just jump in?
Yeah, please.
So just to clarify, Dr. Chant, you were saying there were meetings on the 26th and the 27th. Is that of December?
Yes.
So you must have been concerned if you were convening meetings on a public holiday?
I think of course we were concerned and all actions were being taken, but as I indicated, a lot of the decision points were being, like there was decisions at every point around clinical decisions that needed to be made about what was in the best interest of the patients, issues such as should we immediately close down the ward, and that was considered, the fact that construction had been ceased, the fact that there'd been additional mitigants immediately put in place. And then that was reassessed, balancing where else they could be relocated to and what would be the appropriate communication.
Yep.
So there was lots of decisions being made, and it was important that we kept regularly throughout.
Is it common to have meetings on Boxing Day?
It is common to have meetings.
It was on the 27th.
Yes.
Sorry,
Okay.
Dr. Chan, sorry to correct you, just to say that the meetings were on the 24th, 27th, 29th and 6th
of February. So
Okay.
it wasn't actually on
So,
Boxing
so
Day.
the
it was the day
29th
after.
of December, then nothing till the 6th of February.
That's correct.
But could I just add,
Yeah.
Mrs. Cutter, if I may,
Yeah.
it's also common practice for us. I mean, look, we're a health system, we operate 365 days of the year, so public holidays and weekends
Can I
mean
just say
nothing.
we're very grateful that
Yeah.
that happens.
Really genuinely mean nothing to us because that's the nature of the business that we're in. I think what's also very common for us is that once an issue is identified and there are a series of actions associated with that issue, that then there are meetings that then occur to make sure that the actions that have been determined have in fact been put in place. So it's not uncommon for that sort of cadence of meetings to occur in our system.
And just a quick question, the construction shutdown, that was a permanent shutdown or that was a Christmas period shutdown?
So it was a Christmas period shutdown, which was the context, and that fact that it was shut down was recognised as a factor that meant that the air testing that was conducted there would not be representative of when the construction was reignited. So that was why there was a series of a period of time, I think it was about 5 days or a week, that was allowed when the construction occurred to support the testing in a more real life environment in terms of construction occurring, and that was to validate it. And then there was a meeting held where all the information was presented back of the air modelling, where the expert panel concluded that the facility was safe to be reused.
And the construction has recommenced?
Yes.
And it's
Construction
currently ongoing?
Yeah, the construction shutdown period is consistent across our entire program.
Oh no, I'm just thinking about the transplant. I'm not.
The shutdown and the start up again was entirely as planned. There wasn't an impact on that planned.
So it wasn't shut down to deal with
No.
the IFI?
No.
Oh, okay, thank you.
Okay. Do you have any others on that?
We'll go back to the opposition.
Thank you. Ms. Gulander, if I could ask you a couple of questions. And I confess I am not an expert at building materials or hoarding, so I have taken some advice from some people who are. And with respect to the issue of how the patients were protected with the hoarding that you said had been erected, I understand from people who I've consulted, their advice to me is that complete sealing off of a hospital to stop outside air getting inside is unrealistic. The cladding is most often used to prevent inside air from getting out. Can you comment on the type of cladding and whether it is realistic to seal off the hospital from outside air getting in?
Yeah, I mean, it's not completely realistic to seal off somewhere because doors need to open and close for people to get in and out.
Yes.
In relation to what the purpose of the hoarding is, in this instance it was hoarding to protect from the outside environment into that ward. There are different types of hoarding that can be used as well, and sometimes depending on the sort of type of environment, then different materials might be used. In this instance, there was a sort of plastic sheeting hoarding that when we realised that there were some concerns in relation to it, was replaced with some solid plastic cladding. There's also a sort of secondary point with a door behind that, so there's a couple of layers to access up to where the ward is. It isn't, though, to the second part of your comment, hoarding intended to stop inside air going out. It really was for the protection of the
And it
ward.
was realistic that it could be a seal that would stop outside
in
air
that
from going
location. In that location, but it doesn't stop outside air from coming in. The doors in and out of a ward. There's obviously practices that go with that. There's an operational component to this where you can't, you mitigate as much risk as you can, but realistically, it also relies on the operational procedures and people closing doors behind them and that sort of thing.
Right, okay. And I also wonder if you could give me any information about whether there was increased maintenance of the hospital's HVAC system when there was a known issue.
When there was a known issue, sorry,
was there increased maintenance of the hospital's HVAC system when construction started?
I might have to refer to Ms Wilcox in relation to that because...
okay, thank you. Ms Wilcox, are you able to help us with that?
Yes, certainly. So, yes, there had been some preliminary work done earlier in December to check the filters and check the airflow in the ward.
Sorry if I can take you back.
Yes.
So, when did construction start?
2023.
2023, and was increased maintenance of the HVAC system begun in 2023?
We have annual inspections across all of our wards in terms of their plant and their air handling equipment.
Yes.
And every 3 months those things are serviced, and if there are any issues, obviously they're escalated, and our local engineering team attended.
And given we had a transplant ward next to a construction site, was additional maintenance of the HVAC system undertaken?
Not required, as to the best of my knowledge. That was our routine servicing and looking after our equipment and attending all the normal practices in the transplant ward, which is on a dedicated air system. As Ms Gulander said, it has a door and people go in and out. Yes, there is an internal balcony that had louvers but also had glass door closing it into the ward. So upon the identification of the cluster, we did another round in terms of the filters, turned off the negative pressure because I won't go into the air mechanics, but basically to keep the air still. And then, as I said, a fresh round of filters put into place, and the additional sort of seal put over the balcony hoarding that was already, which was on 2 levels. It wasn't just one area closed, there was another layer, and then we applied the plastic seal to make it sort of like an anti-room, so it was vacuum sealed. And now there's a hard set insertion into that to add to its
So just to make sure I've got it straight, routine maintenance of the HVAC system until December 2025?
It is ongoing. That is a...
No, so when was there the particular intervention? When was the negative pressure turned off, the filters changed?
Yes,
that was December 2025?
No, there was already some work done on the air filters to check on them, check the airflows. That was done in early December.
Right.
And then subsequent to the expert advisory panel meeting on the 24th, we then went about replacing all the filters, just to be abundance of caution around all of this. The maintenance on the ward was being maintained, but we thought best just to remove everything, put something fresh in and make sure we're absolutely confident. And as it turned out, all of the measures that we put in place, when we sampled the air, there was no evidence of any aspergillus, which gave us confidence that our mitigation strategies have been successful.
And just so I understand, because this is not my field,
No.
When I hear you say that now there is in place like a vacuum seal, that in my head says that there's like a spaceship chamber. Is that what's happening?
Now
there's like a vacuum area you walk through?
Now it's a hard set wall in there, so the plastic parts have been removed because as a normal part of the construction, the plan was always to put a hard set wall into where the balcony was, so they can abut the new hospital redevelopment against that wall. So the ward is permanently closed at the moment.
Okay.
But the plastic seal was an additional measure we did, just in abundance of caution around the hoarding closure.
Sorry, the ward is permanently closed. Where are the transplant patients now?
Sorry, the wall. Pardon me.
Wall. Sorry,
my
thank you.
language.
Sorry,
the wall, not the ward. The ward is open.
Yes.
The wall is permanently closed.
Okay.
My apologies.
And that was done as a protective measure, or that was done because it was on the plan for the redevelopment?
It was on the plan.
Right.
Yeah.
Okay. Yeah. Thank you very much. Thank you. I've got a couple of questions for Dr. Morgan now, I think. So, Dr. Morgan, can you tell me how many ambulance stations have been opened since June 2022?
How many ambulance stations?
Yeah, how many new ambulance stations have we had since June 2022?
I might actually ask my health infrastructure colleague whether she's got a particular...
Look, I'm happy.
We'll take it on notice.
Yeah.
We'll try and come back to you.
Yeah, I'll see if we can find the answer.
Because I think there
while
are
we're
a
here.
few of the regional ones that...
Okay, thank you. Because I understand that there was a plan announced then with significant funding attached for 30 new stations as well as a boost in paramedic numbers. Can you tell me how many extra paramedics have been employed since 2022?
Yes, I can.
Could I just ask Mrs. Carter just to clarify when in 2022 are you referring
June
to?
2022.
June 2022.
Thank you.
Okay, so in the first year was 957.
Mm-hmm.
In financial year 24 was 383. That included 125 of the rural 500.
Yep.
And in FY25, 327.
Mm-hmm.
And we're projecting this year by June 30 for 332 additional.
Okay. Okay. And are we keeping all of those paramedics, or is there an attrition rate?
That takes account of the attrition rate. So
what's the? So this is net growth.
That's net growth.
Great. Okay. We're doing well. It's fantastic. Thank you.
Don't sound so surprised, Mrs. Carter.
Sorry?
Don't sound so surprised, please.
No, I'm happy. I'm delighted. It's very good.
Can I honestly say
Yes.
that is a superhuman effort by our education teams and also our recruitment people.
Yes.
It has been stellar. I remember when I returned to New South Wales in 2016, we were debating whether we could do classes of 36 paramedics, and these teams literally pull up every single time, and they're doing 120 quite routinely now. It's quite amazing.
No, that's
Yeah.
excellent news. And so you said 2024, 125 of those were the the rural.
FY25 is another 125 included in the 327.
Great.
And this year we're on track for the third phase of the rural 500 of 125 as well.
Okay. And to the funding for that rural regional paramedic program, was that diversion from capital program for building new ambulance stations? Where did that money come from?
All the rural 500 have basically gone into existing ambulance stations.
No, I'm sorry, but to fund those positions.
Oh no, the capital is completely separate to our operational ongoing funding.
So if I was told that there was a $120 million budget cut in the New South Ambulance Service in 2026, can you comment on that? Well, on any year, I wonder whether
we haven't had a $120 million budget cut. I don't know where that would come from.
Related to that, the allocation for the 500 extra paramedics, so I think it was about just shy of $439 million was the commitment. Does that money go to, is that sort of employing the actual paramedics? Is there a capital works? Is there vehicles with that? What's the breakdown of that 439?
Yeah. So part of that was operational expenditure, so recurrent salaries for the 500, and another part was for fleet and equipment, but largely we've targeted towards where we've had historical overnight on call to retire that because it's really fatiguing. And so we largely had sufficient fleet, which was a significant reprieve for us because we were able to put the staff out there. The remainder of the capital is for doing largely minor works around, for example, when we've gone from a staff of 5 in one location to 12. And so, we've replaced kitchens and, that sort of thing.
Are you able to provide, and I'm happy for it to be on notice, of that 439, a breakdown of those three categories and the funding allocations to sort of staffing costs, capital works and vehicles?
Yes, I think so.
Okay, thank you.
I think it's also worth noting, and Mr. D'Amato might correct me here if I've got this wrong, but over the last about 14 years, the ambulance budget's increased by 170%. So it's had a substantial increase over time.
Great, thank you. And so we've got new paramedics, which is fantastic. How are we going with the bottleneck of unloading? That's probably not the right word. With bringing patients urgently to a hospital and then having that transition from ambulance to hospital happening in a timely fashion.
That's one for Mr. Daly. Mr. Daly, this is your opportunity to shine.
Transfer of care is the formal term.
Yes, thank you. It's much more elegant than unloading. Thank you. Yes.
While Mr. Daly's finding his data, I will add that New South Wales Health is the best performer for ambulance offloads in the country. We outperform Victoria, who have a transfer of care target of 40 minutes. Ours is in 30 minutes, and we still beat them. I just need to get that out because it's a very important thing for us.
But you will appreciate, of course, that
it's just that I've lost a lot of sleep over at Mrs. Carter, and I'd just like to be able to state those things when I get
Where's that energy for beating Victoria on other things?
Yeah. But we are contacted repeatedly by people who have unfortunate experiences in transferal of care.
I could give state-by-state comparison.
What I'm really interested in knowing is we still hear from paramedics that they are spending a lot of time waiting to transfer care. We still hear from patients that they are waiting a long time to transfer care. I'm wondering what the issues are and what levers can be pulled to make an excellent process even better.
Yeah, which is essentially what we aspire to. Unfortunately, like most things in health, there's not a simple solution. And
Could you talk into the microphone, Mr.
sure.
David? Thank you.
Particularly in metropolitan Sydney, the reasons really vary from hospital to hospital. Sometimes it's back-of-house flow, sometimes it's workforce, particularly FACEMs, ED physicians within the department, in order to speed up decision making. So that's why we work individually with an LHD and subsequently with individual hospitals. We have a number of improvement teams that essentially are ED clinicians who come together in teams overseen by the ED task force to go into those individual hospitals and the emergency departments, working with the staff to tailor solutions.
Do we have enough ED clinicians?
I think the FACEM workforce has improved dramatically. I think the
Do we have enough though?
I would think the numbers, yeah, well, I mean...
In regional hospitals, do we have enough?
There'd be paucity in some parts of outer metropolitan Sydney and in some regional areas where I'm sure they'd like to attract more.
And what are we doing to attract more in those areas?
Oh, there's a whole host of workforce issues that go to that.
On notice, could you provide me with a list of all those workforce initiatives to attract?
Yeah, absolutely.
Could I
That'd
just
be great.
add
Thank you.
to this? I think it's also important to note that the government is currently rolling out safe staffing levels to emergency departments, so that does substantially increase the number of nursing staff across the EDs. I was formerly also the co-chair of the Health Workforce Task Force, reporting to health ministers across the country, and there's been substantial effort to assist us in, where necessary, bringing doctors in from overseas to help with some of our workforce maldistribution issues. There is no silver bullet to that issue, and I'm not suggesting that is one single solution, but there has been, and it's ongoingly a challenge, I will say that.
I understand that.
But there are, I know a number of the districts, and Tracy may wish to comment about this, but we've put in place lots of things to welcome people into rural communities as well, because we appreciate that if you do come from another country into Australia and into New South Wales, that transition can be hard, so we seek to make sure that they're well looked after from a social perspective as well as from a workplace perspective.
Can you confirm that welcome program is currently operating?
Yes.
Okay, great, thank you.
Of opposition time, if you want to cut you off before.
Ms. Hoey, if I could ask you quickly, thank you from Justice Health, and thank you for being here. Just wondering, during the psychiatry dispute last year, did you lose any staff specialists who resigned?
I think three of our staff specialists resigned, but we didn't lose any numbers.
Okay, and how were those staff specialist positions filled?
We recruited and filled
As
them.
Staff specialists, VMOs or locums?
Yeah, during the dispute, a number of our staff specialists went on leave without pay from their staff specialist position and moved across to VMO positions.
Yes. How many
I don't have the figures in front of me.
On notice, could I have those figures?
Definitely.
Thank you. Yes.
Yep, surely. Got all that. Yep.
And now the dispute's resolved, do they remain as VMOs or have they become staff specialists again?
No, everybody has gone back to their original positions. That happened quite quickly on the resolution of the dispute.
And the 3 staff specialist positions were filled with external recruitment?
Yeah, we at this point, there may be new vacancies, but we didn't have any vacancies at some point yet. We haven't had the same issues, I think.
Thank you.
Thanks, everyone. We'll break for afternoon tea. We'll be back in 15.
Thank you. I want to ask some questions about workplace safety, psychosocial hazards in the workplace. Is that you, Ms. Abbas, or?
Yes.
Okay. If you can, in one sentence, what is happening at Concord Hospital?
Can you be a bit more specific?
Well, is it common that there be a scheduled secret ballot vote for a vote of no confidence in health management?
It's not common. I do understand, I've only been in the role 8 weeks myself, but I do understand that the Ministry has worked really closely with Concord over the last couple of years on a range of issues, and we've provided a significant level of support to them.
But clearly, from what certainly we're hearing from doctors in particular at Concord, that level of support is insufficient or misplaced, and there's a strong feeling, not just from doctors at Concord but from other hospitals who have approached us, that there isn't a safe mechanism for them to raise issues about safe places of work, safe systems of work, raise issues about that they think are inappropriate with senior staff. What are we doing to create a culture where all members of medical staff feel that they can appropriately report incidents and be heard?
Mrs. Carter, I might, if you don't mind, address that.
Yeah, thank you.
Deb Wilcox is here, who's the Chief Executive, who's responsible for Concord, so she can specifically talk to that, but I might mention it as well. I, along with Minister Park, have created a quarterly meeting with the Statewide Medical Staff Executive Council, and we recently met with them, and they were able to share with us a recent survey of medical staff councils in which there's substantial improvement over the last 5 years in regard to the view of medical staff councils as they relate to the New South Wales Health Executive broadly across the state. I categorically refute any suggestion that there is no safe place for people to raise their issues. Okay. The New South Wales health system absolutely depends on people raising their issues. And it is not to say that every time someone raises an issue that there is agreement as to the substance of that issue. But in regard to Concord in particular, there are a number of things that I would like to put on the record. When issues were identified at Concord 3 years ago now, New South Wales Health, immediately with the former Deputy Secretary in People Governance and Culture, commissioned an assessment of the issues there and actions that were then intended to address them. We then, on top of that, between December 2023 and March 24, sent in Dr. Mary-Ann Gale and another colleague to ensure that those recommendations and action plan were rolled out. We sent them back again in August 2025 to ensure that those recommendations indeed had been rolled out. We have a new Chief Executive for the district. We have a new General Manager for Concord Hospital. I met with the chairs of Medical Staff Council at Sydney Local Health District in August of last year. I attended a combined Medical Staff Council meeting with all medical staff councils in Sydney Local Health District in September of last year, despite the fact that I'd offered to go hospital by hospital and meet with them. We've also commenced a Shaping the System initiative, and we have currently a team led by a clinician, an intensivist, Nee Nguyen from Nepean, going around talking to our system about how we can create and improve better opportunities for people to raise their issues to ensure their voices are heard. As I said, we've established the meetings, Minister Park and I, with the Statewide Medical Staff Executive Council. We know our system's not perfect, and I'm not suggesting it is.
No system ever is.
No system ever is. But in regard to the efforts to address those issues at Concord, I genuinely believe that we have done all that could be reasonably expected of us. That includes me writing to all staff at Concord Hospital, in which I've apologised for the fact that some of those actions were ever required in the first place. I've also apologised verbally, and the People Matter employee survey of Concord Hospital that was conducted last year, which Ms Wilcox can speak to, has shown substantial improvement. Yes. So to put a question to us about what is going on at Concord in terms of cultural safety, I think without referencing that is not the full picture, but I'll hand to Ms Wilcox to further elaborate.
Because I've seen that People Matter survey and I agree, but you would have also, I'm sure, seen the minutes from the meeting of the 6th of February 2026 and the
Which meeting, Mrs. Carter?
Oh, sorry, the meeting, Sydney Local Health District, Medical Staff Executive Council, Concord Repatriation General Hospital Medical Staff Council, the Chair's report, sorry, for the meeting of the 6th of February.
No, I would
I
not
apologise.
normally say
I
those.
thought, because this report has, it acknowledges the changes that have been made, but it then goes through 2 pages, failure to adequately address allegations of bullying and harassment, failure to adequately address the concerns of the Medical Staff Council in the strategic plan, failure to adequately consult in relation to the service agreement between New South Wales Health and Sydney Local Health District, failure to adequately fund the rebuild or maintenance of Concord Repatriation General Hospital, draft social media policy,
So
a whole lot of issues.
I understand that list. Can I say that I respect the fact that people raise issues, and I think that the issues were raised by the Medical Staff Council in Concord in 2023. Absolutely acknowledge that there were things that needed attention. My point is that they received the attention. Myself and Mr. D'Amato, our Chief Financial Officer, as I said, I've met with the Medical Staff Council executive across the district. We've explained our budget setting process and service agreement setting process. I understand why people may feel that the service agreement perhaps doesn't adequately address what they think it should. If you asked anybody across the health system, they probably would say the same. I'm aware of the proposed vote of no confidence that was to be held last week, but I'll leave that to Ms. Wilcox to address. But it is a untenable situation from my perspective to continue to have allegations levelled at myself and my team, for which, for the most part, we are absolutely unable to defend ourselves publicly. When we have done our level best to address those issues, because our view of this is that we want a safe place for our workforce to work in.
Absolutely.
And that means everyone. The Shaping the System work that, as I said, led by Nii Nguyen and Dr. Levesque, who's away presently, is a very substantial piece of work across the state so that we can ensure that the voices of our staff are heard. It doesn't mean, though, that we agree with everything that they say. But Deb, did you want to comment about the meeting on Thursday?
Yes, thank you. The first thing to say is that Concord Hospital is an extremely high-performing hospital. The People Matter survey results really strongly represent the efforts of myself, the General Manager and the whole team to strongly engage with that hospital and engage with staff. I attend sessions called speed dating, I affectionately call them, where people can come and talk to me about anything, 15-minute slots. I visit the hospital regularly. The General Manager is actively engaged with the staff down in the ED on busy days, etc. It is a great culture. It's got a strong community support. It's a terrific hospital. It would be fair to say that there are individuals in staff, like in any organisation, have a slightly different view about matters and continue to raise the same matters in relation to strategic plan, in relation to the service agreement, etc. I'd like to just the committee to understand that these issues have been raised repeatedly and have been repeatedly answered to try and assist certain members of staff that, you know, these are the processes, this is how we do things, and let's keep talking about it. Open door policy, happy to engage at any time, any place. I did attend.
Stop you there, Ms. Wilcox. Is that perhaps an issue? Because if the same issues are being raised and the same answers are being given, does that lead then into a feeling that we're hearing that concerns that are being raised are not being heard?
There may be a very small minority of people, I expect, that may still feel dissatisfied with the responses, but again, I need to emphasise to the committee our efforts to communicate and engage with all staff on all matters has been intense. I've attended hundreds of meetings, engaged with hundreds of staff, and many issues are raised, and everybody's entitled to a response.
If it's just a small group, why then have we got to the point where there is a planned secret ballot vote of no confidence?
I attended the Medical Staff Council meeting last week when this motion of no confidence was to be discussed.
Yes.
There was 2 people who supported it. The remaining members of the Medical Staff Council on the meeting did not and spoke up very strongly that they did not feel this was an appropriate response,
Mm-hmm.
that the local health district and the local management have been highly engaged with the hospital. As I said, the results of the PMS speak for themselves.
Mm-hmm.
They felt like many of the issues were historic, had been prosecuted on many occasions, and that some of the more contemporary issues around primary care, aged care, were valid issues that we should collectively discuss, but they certainly did not support the vote of no confidence.
Okay, thank you. The other issue that we're hearing, and not just from Concord but across, is that there may be not mechanisms within health but also mechanisms internally within the culture of some hospitals, that if more junior doctors want to report something, they feel that they're facing career being blocked, or
By whom?
by more senior doctors, but that's a cultural issue in that hospital. So, what work is being done? I mean, is that a valid concern? If it is, what work is being done to address those cultural issues?
Look, Deb might be able to talk to some of the more specifics, and in fact, Tracy from the Hunt has done a lot of work in this space with junior medical officers as well. It's really important that our staff have the ability to raise issues. And we're also aware that at times the hierarchical nature of health can impede that. You won't be surprised to know that across 185,000 headcount staff in New South Wales Health, I get quite a lot of communication directly from staff within our health system. And I can tell you that I respond to those people every single time.
Thank you.
Because I think it's important that they do express to me at times a degree of trepidation about reaching out. What we're trying to do is establish a system within our health system that no matter who you are, no matter whether you're a junior medical officer, junior registered nurse, a cleaner, a porter, no matter who you are, you have the ability to raise your issues. And this is a very important cultural piece of cultural work, because we are slowly breaking down some of the hierarchical nature of our health system, but it does take time. And my message to our chief executives has been consistent. If it's good enough for me to pick the phone up and talk to someone, it's good enough for anyone.
And are you satisfied that all the chief executives are doing that? They're following your lead?
I am satisfied that our chief executives do their level best to address every issue that they can as quickly as they can.
Thank you.
Could we do it better? Absolutely. But there are forums for junior medical officers where they can come together. There are other forums. The unions obviously advocate on behalf of their members. But this is an area that we genuinely want to see improved. You mentioned the social media policy. Can I just say the social media policy within New South Wales Health is part of a whole of government process. It is not New South Wales Health specific. We have consulted widely with unions and made changes to it as a consequence of that. Of course people need to be able to speak up. But to be perfectly honest, a place for them to speak up is in their workplace. And if that doesn't work, there are other avenues which we publish to our staff. So, you know, the use of social media is fit for many purposes. And people do use it, and they're entitled to use it, of course. But our policy is not designed to quell the voice of our staff from reporting issues.
Thank you. Ms. Overs, can I just pick up this morning, we were talking about conscientious objections. So I'm trying to understand, I didn't believe that there were policies across health for conscientious objection. Are you developing a whole of health policy, or...?
We are developing a policy, yes.
So it will be whole of health, it won't be procedure specific?
We provide guidance, so on issues like this we would provide guidance across the health system.
Sorry, I don't understand. What is the document on which you're working? Does it relate specifically to certain procedures, or is it for the whole of health?
This is for the whole of health.
And what drove the development? This is a new document then?
I will need to come back to you on that. I'm not, unless one of my colleagues can clarify.
Sorry, are you revising an existing document or creating a new document?
I need to come back to you on that, like I said.
Well, so who's doing the work on it?
I'll just check if Mel is able to answer that. Thank you.
She's not sworn in.
I think I might be from last time.
Yeah, she was here last time. Yeah, okay.
Yeah.
So the work's being done by a range of branches in consultation with districts.
And just so I've got it straight in my head, is it a new from scratch document or is it a revised document?
At the moment, it's an existing document, but it may well be, as we review it, we might need a companion document.
So the existing document isn't a whole of health, it I think just relates to specific procedures, doesn't it?
That's right.
Okay, so it's still, the intention is it would still be procedure specific?
I think it's probably too early to answer that. Probably.
What's driving this work? What was the impetus for it?
I didn't start the work. It's been in the works for some time.
Who can answer? I mean, there must be so many projects. Why did this one get to the top?
Oh, well, look, I mean, in terms of our policies, we have regular reviews of all our policies.
Okay.
Generally, our policies are 5-year documents, but some of them...
And is this a 5-year review?
I'd have to take that on notice.
Can you take that on notice?
Yes.
Okay. But if it's going to change from its existing scope to a broader scope, what's driving that piece of work?
Oh, it'll be it's the consultation. So when
consultation with whom? Sorry.
Well, look, all New South Wales health documents and policy directives have a consultation, principally with our staff, with our districts, with other branches of the ministry. To some extent.
And when is the consultation about this document going to occur?
I'll have to take that on notice.
If you could, that'd be great. Thank you. And so at the moment, it's a piece of work, but it's in draft. And
I think we'll have to take the issue on notice, Mrs. Carter. I just don't think we're sufficiently informed to address it today.
Okay, thank you. A couple of quick questions for you, Ms. Wilcox, if I may. I understand that there's a mosquito infestation at RPA. Is that correct?
I wouldn't necessarily describe it as an infestation. There was a complaint about some mosquitoes being in one of our postnatal wards. That was attended to upon being made aware. Clearly we can't spray when there are mothers and babies in the area, so we have to be cautious about how we undertake that.
And is that related to the construction or separate?
It would be mosquitoes in Sydney, wet summer, puddles everywhere with the rain, doors open in the hospital. It would be impossible for me to guess how, but the important thing is once raised, of course that's an unpleasant thing for any patient to experience, and it was attended to promptly, as I understand.
And in relation to the construction, is it true that, I'm guessing it must be the neonatal ward or the maternity ward was moved because of noise issues for the babies?
Yeah, that's correct. As part of the program of works, the work that Health Infrastructure and the construction team are doing is mostly around that eastern end of the hospital. Our neonatal intensive care unit, our intensive care unit, and some of our maternity wards are co-located in those areas.
Yes.
So we've been doing some acoustic monitoring and testing, working through with the construction company just what is happening.
And were they moved? Or
yes, we moved the postnatal ward, we moved that up into level 10 into the block and relocated our geriatric ward. It's a complex build. There will be a lot of dominoes as we move around the site, but importantly, patient safety and comfort, and particularly those of little babies, is absolutely paramount. And I've been stringently overseeing that sound and noise testing to ensure our patients are at the front of our care.
Thank you. Can you answer questions about John Hunter, or is that you? Oh, just a couple of quick questions about John Hunter.
Musical chairs.
Sorry. What did the Hunter New England LHD do to fix the mould growth problem in the John Hunter paediatric outpatient unit reported in February 2025?
So when I reported on that earlier, we just had a program of work. We knew where the mould was. We went through it all. We moved some clinics so that we could clear that space. There was some ceiling tiles that needed to be replaced. And we did it relatively quickly in a few days, but now we've got this monitoring system so that we don't
And so the outbreak in November 2025 was the same process?
Yes, we keep... I think it was the same.
And how often are you getting outbreaks of mould?
It seems to happen around about summertime.
Right. Okay.
The indications are all, why you get mould anywhere. So we've got a program in place to look out for it, especially when we know that it's been detected in the past.
And what does the acronym PODU stand for?
I don't know.
It's a unit at John Hunter Hospitals, apparently.
Protection.
Paediatric outpatients.
I don't think we should be guessing about acronyms.
I have not heard that acronym before.
I think it's in those documents.
Anybody got a best guess?
Sorry,
might
what
be?
was it?
PODU?
No, we'll find that out. And
Yeah,
I'll
we can
guess.
take that on notice.
Yeah, thank you, because I understand that part of John Hunter also has a mould problem.
Sorry.
Yeah, that's on the list as a
Is it the same part of the?
It's a secondary location that's noted
And
with identification
And what
of
is
mould.
PODU? What is that location?
I don't know the answer to that.
Okay.
We'll take that on notice.
sorry.
and
It
we'll
might be
confirm
helpful for the
detail of
committee.
that.
I think it's Paediatric Oncology Day Unit.
Okay, so we think it's Paediatric Oncology Day Unit. Does that sound right?
It could be, and that was part of the in the remediation plan.
Okay, so
Yes.
so the Paediatric Oncology Day Unit was part of the remediation plan. Great, thank you. Mrs. Mitchell?
Yep.